recording. So welcome everyone to our weekly UCSF Orthopedic Surgery Grand Rounds. We have a very special visiting professor today, and for an introduction, I'll turn it over to Dr. Wostrak.
Thank you. So it's my great pleasure to introduce Dr. Carol Morris as our 2021 Orthopedic Oncology Visiting Professor. Dr. Morris completed her undergraduate studies at MIT and then went on to Boston University for medical school. She trained at Boston Medical Center for residency and then went to Memorial Sloan Kettering for her musculoskeletal oncology fellowship. After her fellowship, she joined the faculty at Memorial and became the first female orthopedic oncology faculty there, which is pretty amazing. I just learned that. And then in 2014, after 12 years at Memorial Sloan Kettering, she left to become the chief of orthopedic oncology at Johns Hopkins, where she's also the vice chair of clinical operations. And very notably, she's the current president of the Musculoskeletal Tumor Society. Dr. Morris is a true leader in our field. She is also an unparalleled educator, mentor, as well as leader. When she was the chair of the education committee at the MSTS, she created a comprehensive musculoskeletal oncology curriculum for residents. She is now the current program co-director for the new AAOS Resident Knowledge Curriculum. And this is a huge undertaking, but something that will benefit all of our learners. And so I'm really excited to see some of the curriculum that comes out of that project. I personally feel incredibly lucky to consider Dr. Morris a mentor. As a fellow, she pushed me to become a better physician. Now I often reach out to her for an innovative solution to a difficult case, as we all saw in our case conference. I'm also always thankful for the gentle nudges she has given me along the way when it comes to applying for committees and leadership positions that may feel outside of my comfort zone. Today, she will be giving us a talk entitled Soft Tissue Sarcoma, What's Old is New Again. Thank you and welcome, Dr. Morris.
Rosie and Melissa and Rich, thank you so much for having me. Rosie was the last, I think you were in that last class before I left Memorial. Melissa, you were just coming in the middle of that. And UCSF is really lucky to have both of you. You have a fantastic program at UCSF. And a lot of that is due to Rosie and Melissa and obviously Rich. So thank you for having me. I really wish I could be there in person, but maybe another time. So I'm going to talk about one of my favorite topics, which is soft tissue sarcoma. And I am very interested in the history of medicine and why we do what we do. And to the residents, regardless of what you go into, I really encourage you to question why you're doing what you're doing. Maybe in the middle of a difficult case is not the time to do it, but you should, in general, question why are you doing what you do, and learn a lot about the history of what you do. So this is a history somewhat around soft tissue sarcoma and how it really has shaped where the field is now. I have no financial disclosures relevant to this presentation. So the history of soft tissue sarcoma really starts back in the 1800s. And this picture on the right is a picture of John Rockefeller Jr., who is the son of John D. Rockefeller, who was the nation's richest man at the time. And if you were to correct for inflation now, he still remains the richest person that ever lived in America. He was president of the Standard Oil Company. And John D. Rockefeller had a son, John Jr. And actually everything about this story, interesting though, even though it's over a century old, it's totally applicable in 2021 regarding how we make decisions now and the conflicts of interest that we have around financial incentives and who's paying for what. So anyway, John Jr. Went to boarding school on the Upper East Side, as you do when you have a lot of money like that. And his roommate's sister was this woman, Bessie Daschle. And they became very close friends. And when they graduated from high school, Bessie took a train across the country to travel for the summer. And she got her hands stuck between two seats on a train car. And when she came back to New York, she showed John Jr., hey, my hand is hurt. And she had this big red hand. And so they immediately took her to a doctor. And they took her to see this young new whippersnapper doctor in New York City who is at what we now call New York Hospital. It wasn't called New York Hospital back then, over there on the Upper East Side. This guy named William Coley. William Coley had just finished his medical training, and he was the hot surgeon in New York. And he did what most surgeons did. Oh, she must have an infection. And he treated her for an infection, and it didn't go away. And he treated her again for an infection, and it didn't go away. And he eventually did a biopsy. And the biopsy turned out to show a small round blue cell tumor. Probably what we now know is Ewing sarcoma. Could have been an epithelioid sarcoma. And she had what people had back then in the late 1800s for sarcoma. She had an amputation the next day. And so she underwent this above elbow amputation for a small round blue cell sarcoma in her hand. And 2 months later, she died a really miserable death. And it really affected William Coley. According to reports, he was actually quite depressed about it. But he pulled himself together, and he decided that he was going to devote his life to treating sarcomas. And so he went to the medical records at New York Hospital, and he did this retrospective review of patients with soft tissue sarcoma. And he found a patient that had a head and neck sarcoma that lived on the Lower East Side. And this guy had this recurrent tumor behind his ear. It fungated, it got infected with what was called erysipelas back then, which we now know is a strep pyrogenes. It got infected. The doctors there said, we can't do anything for you. Go home to hospice. 7 years later, he found this patient. The guy was alive. And the tumor spontaneously regressed. And Coley was absolutely convinced that the reason that the tumor progressed was because of the infection. And so he went down this road of studying the relationship of infection to curing cancer, and specifically for sarcomas. And so in 1891, he injected a patient with erysipelas, and the patient lived. The sarcoma regressed, and the patient went on to live. And so then he started injecting patients with this live Streptococcus. Now, not all cases turned out like that. The next 2 patients that he injected died. And they died not from the sarcoma, but they died from sepsis, from injecting this live Streptococcus. And so he figured out that if he could, he'd kill the Streptococcus. And he started playing with all these things and mixing things together. Long story short, he invented this thing called Coley's toxin. And Coley's toxin was made up of heat-killed Streptococcus and another bacteria called Serratia. And he started injecting patients with this Coley's toxin. And this is his first report on that, on these 3 patients that he injected. He went on to do this for the next several decades. And I can't see people's faces, but how many people have you ever even heard of Coley or Coley's toxin? You know, probably not very many at all. But his daughter went on to become a scientist as well, and cataloged all his cases. He ended up treating 1,000 patients with Coley's toxin, and with several hundred actually having a durable response. So that's quite questionable. And so, you know, one of the questions is, why haven't people heard of William Coley? And I argue that one of the reasons is that I think there are 2 people that are responsible for you not hearing of William Coley. And I'm going to actually, throughout this talk, I'm going to tell you a couple of books that I think you should read. The first person that probably is a reason you haven't heard of William Coley is Marie Curie. Marie Curie is a rock star. She is one of my heroes. The woman was brilliant. She was absolutely brilliant. She was born in Poland. She graduated first in her high school class. In Poland, women couldn't go to college back then. So her parents sent her and her sister to Paris. She went to the Sorbonne in Paris. She got first woman to get a PhD in all of Europe in physics. She studied mathematics and chemistry as well. She met her future husband there, Pierre Curie. Pierre Curie's claim to fame was that he made scientific instruments to measure things. And she became fascinated with this concept of radium. Actually, she discovered radium. She became fascinated with being able to measure radioactive radioactivity from natural substances. And so she actually purified and found radium, measured its radioactivity, and introduced this concept of radioactivity. She was awarded the Nobel Prize in Physics in 1903 for that work. The Nobel Committee actually did not want to give her the prize because she was a woman at the time. Her husband had to actually tell the Nobel Committee, no, these are her experiments, this was her idea. And both of them ended up getting the Nobel Prize together. She got a second Nobel Prize. I mean, really, she was really quite an incredible person. She got a second Nobel Prize in chemistry in 1911. And unfortunately, she ended up dying from anaplastic anemia related to all that radium exposure, because people didn't understand the hazards of radium at that time. Probably the most important person that is responsible for people not knowing about Coley is James Ewing. James Ewing was the first full-time pathologist at Cornell Medical Center, or what we now call New York Hospital. And he was very much a famous man in his own right. There's an eponymous tumor named after him, Ewing sarcoma, a small round blue cell tumor. But Ewing went to Europe in 1913 to better understand the medicinal effects of radiation. And he came back to the US and he was a convert. And he was like, radiation is the way to go. We need to be treating cancer with radiation. And he ended up partnering with this guy, James Douglas. James Douglas had a daughter that died from breast cancer. Despite his many attempts to cure her, he actually took his daughter to Europe to try to get her radiated and cured. James Douglas was a very wealthy man. He was a philanthropist. He was a copper miner in Colorado. And long story short, James Douglas felt that the US was behind on this, and he wanted the US to have more of a presence in radiation oncology. And he and James Ewing formed a partnership to try to make that happen. James Ewing at the time forbid Coley. So James Ewing ended up being Coley's boss. And Coley didn't really have a scientific background. He couldn't explain why Coley's toxin worked so well. The framework for understanding immunology didn't exist at that time. And so he couldn't prove that what he was doing actually made scientific sense. And so Coley was kind of pushed out. Radiation took over. The US started mining a lot of radiation. James Douglas ended up buying a mine in Colorado. He started mining radium. Anytime there's a good thing going on, the government gets involved. The US Bureau of Mines at the time then decided they had to regulate radium. Something called the National Radium Institute was formed. It was headed by James Douglas, who was affiliated with the New York Hospital, and Howard Kelly. So Howard Kelly was one of the founding forefathers of Johns Hopkins. And they joined forces, and they mined a lot of radium for the United States. And radium was so popular back then, it was then put into widely used for commercial purposes. They put it in toothpaste. There was radium in toothpaste. There was radium in bath salts to treat rheumatism. It was marketed as something called Undark. And they put it on everything. They put radium in matches. Radium was all over the place. And they viewed it back then as a panacea. People drank it. In fact, actually, James Douglas drank a little pitcher of radium every day. You can guess what he died of. He died of leukemia also. So anyway, so James Douglas stipulated in his will that if, and by that time, New York Hospital was then called Memorial Hospital. Ewing had gone to the board at Memorial Hospital and said, we should really make this a cancer hospital. The board was like, no, there's no money in cancer. People die of cancer. It's a terminal disease. James Douglas put in his will that if Memorial agreed to become a pure cancer hospital, he would donate his entire personal supply of radium, which was the largest in the country at the time, to the hospital. And in exchange for that, make James Ewing the president of the hospital. They agreed to do it. Memorial Hospital for Cancer and Allied Disease was born when Douglas died. Memorial got a humongous amount of radium. Howard Kelly brought his radium back to Johns Hopkins. It's not exactly sure what happened to that radium. Some nefarious things happened in Baltimore back then, though, when it came to radiation. And the National Radium Institute was closed and went under private investment. The most telling story from radium was this one. This is another book I encourage people to read. It's called Radium Girls. One of the biggest commercial uses of radium at the time was to paint these glow-in-the-dark dials on watches. And this was popular during the war because the guys in the trenches needed to look down at a timepiece and tell what time it was. And to paint these radium dials, the company in New Jersey that made these, they hired these young women right out of high school, and the way they painted them is they took a paintbrush and they wet it with their lips, dipped it in the radium salts, and then painted the dials. And so these women were constantly ingesting radium directly. And you can see in this picture on the right, they ended up getting these massive osteosarcomas, and hundreds of them got sarcomas, actually. They brought a lawsuit. I promise I'll get back to soft tissue sarcoma, but it is all related, and I'm going to get to there in the end as well. They ended up bringing a lawsuit against the radium, the watch dial company, and 6 of them band together. They all had osteosarcomas and other soft tissue sarcomas. They actually had a tough time winning. They never won their lawsuit. And why didn't they win their law? One of the reasons they didn't win their lawsuit, the company hired a physician to do exams on them and say that radium was not the cause of their problems. You know who that physician was? James Ewing, actually, if you can believe it. And so they ended up settling out of court, and got some measly pittance for all this. But because of that case, actually, OSHA was founded in this country, and now we have workplace protection throughout the workforce. Coley basically was villainized for his work because the radium took over. It was very lucrative, and that became the mainstay for treating cancer in the United States and around the world. What was then the American Cancer Society at the time, now we call it the American Cancer Society, but what it was called at that time, they basically came out and made a statement. There's no scientific evidence that Coley's toxins alone are effective in treating cancer. Who was president of the American Cancer Society? James Ewing. And so he was very instrumental in erasing this memory, actually, of Coley and Coley's toxins. I'll get back to him at the end, but our field is coming right back around to Coley's discoveries and where it's going. And if you look at some of the evidence out there now, this was a paper presented at the Musculoskeletal Tumor Society meeting in 2005, and it was a group from the UK. And they looked at their patients with osteosarcoma that underwent distal femur replacement. And these are the results. If the patient got an infection, they had a 20% chance of better survival than the patients that didn't get an infection, which is really quite remarkable. So Rosie and Rich and Melissa, when your patients come in with their infected prosthesis, say, you're damn lucky to have that infection because it's going to cure you. And this has been shown in study after study. It's been shown in dogs. It's been shown in other patients with osteosarcoma as well. There's certainly literature out there to question this. And obviously infection alone is not the answer, but it is compelling. It's very compelling, this concept of purposefully infecting something to elicit an inflammatory response and have that fight the body's cancer. And so we're going to go through soft tissue sarcoma and see how it's coming right back around to where Coley started this over a century ago. And so on the topic of soft tissue sarcoma, there are about 13,500 cases diagnosed annually in the US. They're an orphan disease. They represent less than 1% of all adult cancers, but 15, even close to 20% of pediatric cancers. The distribution of soft tissue sarcomas is as follows. Half will be in the extremity and the other half will be in any place where you have connective tissue. On clinical presentation, patients will often complain of a lump or bump of growth. And, and I show this to emphasize, people think that cancer is painful. Bone cancers are painful, but soft tissue sarcomas tend not to be painful. So residents, when you see a mass in clinic, a lot of people go into sports medicine, when you see those masses behind the knee, Just because it doesn't hurt doesn't mean that it's not dangerous for a sarcoma. So most sarcomas are not painful. In fact, they tend to only be painful when they're invading into a bone or causing some type of nerve compression. And some vascular tumors certainly can be painful as well. When you see a patient with a mass in clinic, it's important to actually lay your hands on the patient. You want to measure the mass. I give all my residents a little tape measure. You should palpate it, see if it's firm or soft. You should take it and see if you can move it. Is it mobile? Is it fixed? If it's superficial, does it transilluminate? You want to examine the entire extremity, including those regional lymph nodes. And a take-home message is anything that's bigger than a golf ball, anything that's greater than 5 centimeters, anything that's deep, anything that's fixed is a malignancy until proven otherwise, and you should approach it that way and treat it that way. Once you're suspecting or you've confirmed a soft tissue sarcoma, then you want to stage a patient for soft tissue sarcoma. And we talked about this in the conference this morning. Staging studies are directed at an extent of disease workup where the tumor is most likely to go. And it has to be practical, they have to be paid for. And so the CMS pays for studies that the NCCN says that you should pay for. Melissa Zemmel, I think you said on the soft tissue committee for NCCN. So for those of you that can get reimbursed, you should take that out on Melissa. She's the one that's helped dictate what can get reimbursed for staging studies in soft tissue sarcoma. But if you have a patient with soft tissue sarcoma, you want to get an MRI of the entire extremity, of the entire compartment, I should say. CT scan of the lungs, most common site, and you're going to do a biopsy. There are certainly some special considerations in disease subtypes. Namely, there are certain sarcomas that will go to lymph nodes, and a sentinel lymph node biopsy should be part of the staging system. The two most common for that will be an epithelioid sarcoma and a rhabdomyosarcoma. Those are nice boards questions, Chief Residents. And there's a tumor called myxoid liposarcoma that tends to have a high tendency to have extrapulmonary metastases. And so we will get a CT chest, abdomen, and pelvis for those patients. MRI is currently the gold standard for looking at a soft tissue mass in the limb. It has excellent definition of the boundaries of the tumor and the adjacent neurovascular structures. When we get MRIs, we usually get T1s, fat suppressed T2s, and we always give gadolinium. Gadolinium is important for a bunch of reasons. If you have masses, most orthopedic surgeons, right, you're going to run into a mass in a periarticular location. Obviously, benign tumors and things like cysts are more common than malignant tumors. And when you're not sure what something is, gadolinium is a great way to try to differentiate that. Solid things tend to show heterogeneous enhancement with gadolinium, whereas something like a benign cyst, it has this peripheral only rim of enhancement and you have no central enhancement. And when you see that on an MRI, you can be very confident that that is a cyst and nothing more worrisome, and then treat it accordingly. So here's an example. Here's a big mass behind the knee. It's homogeneous, and homogeneous masses are particularly tricky. That can be fluid, but they can also be myxoid, and there are a lot of myxoid containing neoplasm. So is this solid? Is it cystic? I think before you operate on a patient, you must prove that, or before you decide you're not going to follow a patient, you must prove that in fact it is not a solid mass. And certainly gadolinium, you can see down here on the bottom. If you give gadolinium to this patient, you have this rim enhancement, no central enhancement, you're confident it's a cyst. Ultrasound is certainly another way to accomplish that as well. It's cheaper and certainly can be easier to get, but I think you should prove it one way or the other. Here's another example. Here's a small heterogeneous mass, periarticular. Is it solid? Is it a cyst? You give gadolinium, and this has heterogeneous central enhancement. That is not a cyst. That is not a cyst. That's a solid mass. And the reason it looks so homogeneous is that it's myxoid containing. And this, in fact, is a extraskeletal myxoid chondrosarcoma. PET scans. Do we get PET scans in sarcomas? We do. They are not approved for the purposes of staging in most soft tissue sarcomas, so they can be very hard for an insurance to convince an insurance company to pay for them. But certainly PET scans can be useful for those sarcomas that do have lymph node metastases, such as in epithelioid sarcoma in the hand, and you see this positive axillary node. PET scans can also be useful when you're trying to distinguish between benign versus malignant tumors. And neurofibromatosis is such a disease where patients can get very large neurofibromas. And there is some work to suggest that the avidity of FDG on PET scan can help distinguish a benign versus a malignant nerve sheath tumor. Going forward, certainly our institution, we are using what we call these functional MRI sequences to help make some call on these things. And this is just an example of one functional MRI sequence. The patient gets gadolinium, and then you can actually measure how quickly that gadolinium is taken up. This does have some value for distinguishing benign versus malignant. We use it more for treatment response in a tumor that's given either pre-op chemotherapy or pre-op radiation therapy. And in this graph on the right, when you see this sharp upward slope, we call that early arterial enhancement. That means something is very viable, it's very much alive, and so that's something with a poor response. Whereas this graph on the left, you have late arterial enhancement. That would imply that something is more necrotic and has probably had a good response to treatment. This is another type of functional MRI. This is a lot of work done by Dr. Fayette at Hopkins, who has a big interest in this. And this is a technique called diffusion weighted imaging. And what that does, it actually measures the motion of water in that tumor. And if the water can move really quickly, that's called, it has a high ADC value, apparent diffusion coefficient value. And so if it's moving really quickly, if the ADC is high, again, that implies that's something that's more necrotic and has had a good response. Where if it's moving really slowly, that means the water is more restricted, and that's something that is probably more viable. Dr. Levin and I at Hopkins are looking at magnetic resonance spectroscopy for the purposes of differentiating those tumors that fall into that benign versus malignant category, and we're not sure. One example of that are you have these large, deep-seated fatty masses, and you're not quite sure how they're going to behave. Are they behaving more like lipomas, or they're going to behave more like liposarcomas? And MR spectroscopy is a way to do that. It actually measures metabolites within a tumor, and we looked at benign lipomas, benign subcutaneous fat, and these ALTs. We actually also have done some work on dedifferentiated liposarcomas as well, and there clearly is a distinct metabolic profile for each of those entities. And so that probably has some promise too. All right, so you've done your imaging, you're convinced you have a sarcoma, now you need to do a biopsy. A biopsy is perceived by patients and physicians to be this simple, low-risk procedure. I actually, out of all the, when we take residents through cases, I actually am most hands-on on the biopsy because it's so easy to mess up. And a bad biopsy burns a lot of bridges for a patient down the road. When you guys rotate on tumor, you're probably not going to do hemipelvectomies in your career, but almost all of you are going to have to biopsy something in your career. And that is probably the one procedure I would concentrate on as a resident, how to do a good biopsy, because it's really easy to do a bad biopsy. It's not technically demanding, but there are a lot of considerations. And I always say it's the first step of a successful limb salvage operation. I'm sure that your group there has taught you all about biopsies, but there are a lot of different types of biopsies to do. Which to do is called a tumor fellowship to actually understand the nuances of which one is best. But the main take-home message here is if you're going to do biopsies, draw out that limb salvage incision. Make sure wherever you decide to do that biopsy, you can incorporate it into a surgery that will allow for limb salvage. There are a lot of biopsy complications out there. Transverse incisions, poor hemostasis, doing it through an arthroscopy portal, having the drain exit really far away. That in and of itself could be a grand rounds, but just to drive home that point, biopsy technique is really key for patients' successful outcome. Once we have that tissue, it goes to pathology. Pathology then uses a variety of things to make a diagnosis. Historically, and even currently, most histologic diagnoses are made on morphology. So in other words, a liposarcoma. A liposarcoma does not come from fat. A liposarcoma is a malignant mesenchymal tumor that goes down the differentiation pathway most closely associated with fat. So it looks like fat under a microscope. Same thing for nerve sheath tumors. These aren't malignant nerves. This is malignant mesenchymal tissue that goes down a neural differentiation pathway, and so forth and so on, myofibroblastic. These are tricky though. You need a lot of experience as a pathologist to make accurate calls. There aren't that many sarcoma pathologists in the country, just like there aren't that many sarcoma surgeons in the country. And this is a really challenging entity for pathologists. These are really challenging entity for sarcoma pathologists. And so certainly the field has become much more sophisticated. There are many simple mutations that are now used to classify tumors, and cancer in general, not just sarcomas, are very much enjoying this time of molecular classification. Certainly our hematology colleagues are ahead of us on this, and the lymphomas and things like that, leukemias, are very much molecular diagnoses now. Sarcomas are a little further behind, but certainly we have identified many sarcomas with translocations that are pathognomonic for that tumor, and certain NF1 gene activation will give you MPNST, so forth and so on. Certainly the field has exploded over the last decade. Next generation sequencing is probably the standard at most of the big academic medical centers now. And these next gen panels, on the panel in the middle, you can take a set of genes and look for them in a tumor. These genetic panels can look for 50 genes up to a couple of hundred genes, or maybe in some cases 1,000 genes. There's some places this probably is impractical, where they're even sequencing the whole genome of that tumor. Is it making a difference in what we're doing yet? Not really, not really. It's very expensive. There aren't a lot of huge series out there, but there are some from here in the US and some from the UK. They don't really change the diagnosis that much. I think in the series from the UK, 3% of the time the diagnosis was changed when they did this whole genome sequencing. But the real purpose of this is to try to find targets, therapeutic targets that can be developed for drug development to treat patients with these tumors. And big data, it takes a lot of resources and money to even analyze all this data. I have no financial relationships with any of these. There are a lot of big data companies right now crunching all of this genomic data to try to find out which genes are oncogenic and are they associated with drug development. And these are just two examples of that. So this is sort of the future of I think, of cancer, this precision medicine concept, where you take a patient's tumor, you sequence it, you throw all that data into a big informatics database and try to come up with the right treatment for them. All right, so now that you've gotten all the information, you've gotten the imaging, you've gotten the histology, now you stage the patient. In 2021, we're using the 8th edition of the AJCC, which is used to come up with a sarcoma stage, and it's based on grade, high grade or low grade. It's based on the size. The 8th edition stratifies by size in these 5 centimeter increments, and it's based on metastases. Chief residents, the good news is the data is too new. It won't be on your boards, so you don't have to memorize it right now. Those a little younger, it just might be. All right, so you stage the patient, and now you have to treat the patient. And sarcomas are very, very much multidisciplinary team tumors. And if you go to the UCSF website, you certainly, you guys have that nice picture of your sarcoma team, but it very much is a team sport. It's not just the surgeon. But the 3 cornerstones of sarcoma treatment are surgery, radiation, and chemotherapy. And you certainly need all these other players to help you get the patient through as well. So surgery, number 1, almost all sarcomas are going to be treated with surgery. This is your classification of surgical procedures. Intralesional means you're in a tumor. Marginal means you're around that pseudocapsule of the tumor. We call that the reactive zone sometimes on an MRI. Wide excision means just a cup of normal tissue. And a radical resection means you're taking out an entire compartment. And the entire compartment here would be from the pelvis all the way down to the knee, so a little impractical. In this day and age, wide excision is the treatment of choice for most soft tissue sarcomas. Certainly in the past, as I said earlier in my talk, if you came in with a sarcoma, actually just even as probably a few decades ago, you were amputated. And in 2021, if you look at most large series, probably 5% of people end up having amputation up front. And the main indications for amputation, when it's really impossible to achieve a tumor-free margin, if the tumor is just so large, if it's salvage for recurrence or contaminated surgery, as in this picture on the left, you have a drain site here coming out the knee and coming out the anterior thigh. This is a hard thing to salvage. Or when the function is going to be superior with amputation compared to limb salvage. And one might argue that in this example on the bottom, this would require wide excision, free flap reconstruction, radiation, and perhaps below knee amputation in a young patient might be superior to the function that limb salvage might offer. What's the data for amputation versus limb salvage? One of the residents had texted this in one of the chats this morning. There's only been one randomized trial on this topic. It was from the NCI, and they randomized patients to amputation versus limb sparing surgery with radiation. And here's the data. The data says that if you get an amputation, your local recurrence, meaning tumor coming back in the same spot, is superior. Survival is exactly the same. So amputation versus limb salvage, survival is the same, but it does impact local control. There have been some other retrospective series, this is probably the largest one out there, that simply prove the same thing. Amputation versus limb salvage, no effect on survival, but improved local control. So most patients get limb salvage. In the past, we used to do these radical resections, and that's before we had MRIs and really understood that often tumors really were localized to a single spot. There certainly are some indications for radical resections, and this is just an example of that. Here is a tumor in the back of the thigh. You still have some enhancement out beyond the pseudocapsule of the tumor. The group in Toronto very eloquently did a histologic analysis on these scenarios and found that you could have these satellite tumor cells up to 4 centimeters away in the reactive zone. And so there still is a role for radical resection, cutting out that entire compartment, but it's pretty limited. As I said, in this day and age, wide excision, that will certainly be on your boards, is the treatment of choice for any soft tissue sarcoma or bone sarcoma. Wide excision simply means a cup of normal tissue. Again, you want to try to do that needle biopsy along your limb salvage incision. We have debates at our MSTS meeting sometimes or whether it's necessary to take out a needle track versus leaving it behind. I think this is, when I did this case, this was before pre-op radiation really was in vogue, and we were doing a lot of post-op radiation here. So this patient was biopsied and taken to surgery. And you can see in this example, at least, where the needle went in, it poked through the fascia, and it allowed the tumor to herniate up into the subcutaneous tissue. And so that always stuck with me, that this is a very strong argument to excise these needle biopsy tracks. In 2021, a lot of places are doing pre-op radiation, though, and that may very well take care of that problem. What's the future in surgery? This is work from Dr. Levin, my colleague here. He is using this 5-ALA aminolevulinic acid as a tumor paint. And so he's done some in vitro work to show that if you take the surrounding normal tissue, and in this case he used fat, and exposed it to 5-ALA, and then take myxofibrosarcoma cells and expose those to 5-ALA, that the myxofibrosarcoma cells, once you wash them out, hold on to their fluorescence. He then took that in vitro and applied it in a mouse model, and took a mouse model with fibrosarcoma, injected this 5-ALA, localized a tumor on this micro PET CT, and then used a blue light to cut down on the tumor, and then took that out, harvested, and did histology on it. And it's a way to try to localize some of these tumors intraoperatively that can be very difficult. There are some tumor histologic subtypes like myxofibrosarcoma that are very infiltrative, and it's a huge challenge intraoperatively to know where to stop cutting. And so this is just one way to try to do that. And hopefully he continues down this road and can make something like this available to the sarcoma world, because I think it would be very helpful. All right, so that's surgery. Armamentarium point number 2 is radiation. When do we give radiation? Why do we give radiation? What is radiation? So the purpose of radiation is to improve local tumor control. It helps to decrease a tumor from coming back in that one spot. And it does that by killing microscopic disease. It causes DNA strand breaks. Those strand breaks cause apoptosis, and the cells die. There are many ways to give radiation. You can give what's called external beam radiation. That is certainly what we use most commonly. in orthopedic oncology. You can do intraoperative radiation therapy. People that take out retroperitoneal sarcomas will often use intraoperative radiation therapy. And then there's a technique called brachytherapy, where you deliver seeds. An example of prostate cancer is often treated with brachytherapy. The typical therapeutic doses for soft tissue sarcoma are listed here. If you get radiation pre-op, you usually get about 5,000 centigrade. If you get it post-op, you get about 6,600 centigrade. It's given in fractions. You can't give 5,000 all at one time. You have to break it up into fractions. And so it takes about 5 weeks or 6 weeks to get that much radiation into someone. Most places use photons as a delivery source for that radiation. This is an example of a particle accelerator. It accelerates the photons. The photons are emitted out through a tiny aperture to the tumor. It causes those DNA strand breaks, causes apoptosis, and you kill the tumor. In the past, a lot of brachytherapy was done for soft tissue sarcoma. I have not seen brachytherapy done since I was a fellow. I don't know if you guys use it at UCSF at all for extremity soft tissue sarcoma. Conventional external beam radiation therapy refers to, if this is your tumor, everything that's here in red is getting the same radiation dose. Not desirable. You don't want to give your muscle and your bone the same radiation dose as you're giving the primary tumor. So in 2021, most places are using this thing called IMRT, intensity modulated radiation therapy, where they can bend the beam to give the highest dose to the tumor and give lower doses to the surrounding structures. And certainly that has a lot of implications. There are a lot of radiation side effects. And if you can minimize the doses to the surrounding structures from radiation, certainly in the long run, patients have fewer side effects down the road. There's even some evidence to show it has superior local control to conventional external beam radiation therapy. What's the data? What's the data? So here's the data you need to know. Prospective randomized trial from the NCI. They randomized patients with high-grade extremity sarcomas to radiation versus no radiation. Those patients that got radiation, 0% local recurrence. Those patients that didn't get radiation, 20% local recurrence. I will say this, I look at this and I say anything with 0%, anything is always suspect. Nothing is 0% or 100%, but in this study it was 0%. Certainly the data was confounded by the fact that all these patients got post-op chemo, but neither here nor there. This is the cleanest data that we have and the best randomized trial on the subject. So does it work? Yes. Radiation decreases local recurrence in soft tissue sarcoma in the order of the 20 to 25% range. What impact does it have on survival? 0. Same survival. So it's a local control measure only. As I said, radiation side effects are plentiful. This is actually the focus of my research here at Hopkins. I do a lot of work on radiation side effects and trying to understand those better and mitigate the side effects from radiation. For the purposes of your boards, the biggest ones you need to know about that are orthopedically relevant are wound complications are worse with radiation. People get radiation fractures, as we talked about in conference this morning, and secondary malignancies are real. You can get secondary sarcomas in the radiation field. Do you give it pre-op? Do you give it post-op? There's a lot of geographic variability on this topic around the world and even around the country. The group from Toronto, again, they did this very nice randomized trial. Their endpoint was wound complications, but they did this very nice trial. If you gave pre-op radiation, it increased your wound complications by 2. 18% of the patients that didn't get pre-op radiation had wound complications compared to like 35 or 36 patients that did have radiation. So radiation pre-op increases wound complications. Radiation post-op gives you more late effects. And what are those late effects? Again, fractures, fibrosis, edema, all of those types of things. The thinking is we can manage wound complications, but we don't know how to manage late effects. And so there tends to be a preference around the country to give pre-op radiation over post-op radiation for that reason. It's a smaller volume, fewer late effects. Not everyone subscribes to that. I think the pendulum swings back and forth. If I were to survey I think most people are giving pre-op. I'm curious to see what you guys do here. What's on the horizon for radiation therapy in the future? There's a technique called image-guided radiation, and these future techniques are really to make them more pinpoint, where you image the patient every single day to make sure that, again, to try to minimize collateral damage. Probably what people have heard of more are protons. Patients come in all the time now saying, what about proton therapy? Can I get protons? And protons, it's a heavier particle than a photon. The physicist is able to control where that particle goes. And so proton therapy is used a lot in the brain, in the spine, in areas of the body where you really want to minimize the radiation to the surrounding structures. I don't really think they have a huge role in sarcoma. You know, there are some microscopic cells outside of that pseudocapsule, so you actually want that field to be a little less tight. You know, if it's too tight. I don't have any data to support that statement, whether it's associated with increased local recurrence, but that would be my gut feeling. But there are certainly radiation is making its own strides as well. Okay, and then last one, number 3, chemotherapy. What do we do with chemotherapy? Chemotherapy is exceedingly controversial for adult soft tissue sarcoma. There is, again, tremendous variability around the country, whether to even give chemotherapy in adult soft tissue sarcoma. Most people agree it's not indicated for low-grade tumors. Most people agree it's probably not indicated for small tumors in adults. Most people agree that if you have advanced disease like stage 4, you should try chemotherapy or some type of clinical trial. But these are the tumors that we're most commonly seeing, these stage 3 tumors. They're big, they're deep, and they're at huge risk of developing distant metastases. And so is there anything we can do for this group of patients to try to minimize the risk of metastases? The 2 drugs that we have at our disposal are doxorubicin and ifosfamide. And it's been like that for 40 years. And so here is the timeline for chemotherapy. So in the 70s and 80s, those were the first round of phase 1 trials using single agent doxorubicin. And in 1997, a meta-analysis came out in the Lancet, and it looked at these 23 doxorubicin-based trials, and this is what they found in the meta-analysis, that if you had an extremity sarcoma, there was only a 7% benefit to getting doxorubicin. The naysayers of this said, you know what, the reason that it's so low is because it's single agent, and we know in osteosarcoma, you need multiple agents. You need multi-agent chemotherapy. So in the 90s, they did a second generation of randomized trials to include ifosfamide. So you have your doxorubicin and ifosfamide being done in these randomized trials now. In the meantime, you had some big single centers reporting their results. Here's the Italian sarcoma group. They gave pre-op chemotherapy, and lo and behold, their disease-free survival was spectacular if you gave chemotherapy. What ruins a good result? Follow up, and if they followed them a little longer, at 5 years, it actually had no difference. And so they had to backpedal on those results. So if you followed them out long enough, chemotherapy delayed the presence of those metastases coming, but they still came. They still came. The 2 biggest sarcoma centers in the country, MD Anderson and Memorial, they pooled their data. This is a retrospective study, but when they pooled all their data, they found the same thing. If you got chemo versus if you didn't get chemo, there was no difference in survival. And then in 2007, they went back and did a meta-analysis again on the doxorubicin and ifosfamide data. It made no difference. 6% overall survival. We actually lost a percentage point. So there are a lot of criticisms around this. And so this was the largest randomized trial done on the topic. This is the European data. And they randomized patients to chemotherapy versus no chemotherapy. And this is their outcome, absolutely the same. So the largest randomized trial, well-done trial, shows that whether you give chemotherapy or you don't give chemotherapy in adult soft tissue sarcoma, survival is the same. Doesn't stop us from giving it though, but survival is the same. And so does it work for soft tissue sarcoma? The answer is, if you have a pediatric sarcoma, absolutely. It does work for Ewing sarcoma, works for rhabdomyosarcoma. And certainly in certain histologic subtypes, you will see some improvement with single agents. But overall, probably doesn't make a big difference. You know, what's the future? The future is about targeted therapy. It's about harnessing all that big data to try to find targets. These are some of the targets that have been made into commercial use. IDH1 and 2 inhibitors that can be used in a subset of chondrosarcoma. Tenosynovial giant cell tumors now have some targeted therapy that can be used instead of surgery, you know, so forth and so on. But certainly the rage is all immunotherapy. This is the cover of Science magazine in 2013. And there has just been an explosion of immunotherapy research, immunotherapy drugs for the purposes of cancer. And even in sarcoma, it's a hot topic right now too. For sarcomas, these two mechanisms, checkpoint inhibitors and T-cell adoptive therapy, seem to be the most promising. If you look at the timeline for immunotherapy in sarcoma, it all started back in the late 1800s with Coley. He really was onto something. You know, as I said before, people did not understand the immune system. They didn't have a context in which to understand his work. But then it slowly started coming out. Morton figured out that lymphocytes did in fact induce some resistance in cancer. It took another 50 years, but in Europe, this group actually showed that if you injected these rats that had fibrosarcoma with lymphocytes, you could induce, it would kill the tumor. And that sort of jump-started everything, and everything really took off. What really jump-started the field of immunotherapy, though, was the discovery of interleukin-2. Interleukin-2 allowed scientists to grow T cells in vitro. And by doing that, and this is a landmark paper that made it clinically relevant. This is the Rosenberg paper in the New England Journal of Medicine in 1988. He took some patients with metastatic melanoma, took out their T cells, grew them up, reimplanted those T cells, and like 11 of 15 patients had an objective response, and a couple of them had a durable response. And that just, you know, it's spurred the field to really take off. And then paper after paper after paper came out on this concept of using T cell therapy in solid tumors and in sarcomas in general. And this is the most recent chart I could find. There are a lot, not a lot, compared to some other tumors. There are a lot of immunotherapy trials though going on for sarcomas right now, and this list continues to grow. Sarcoma in general has a lot of limitations. The first one being, it's a really heterogeneous group of tumors. There is no disease called soft tissue sarcoma. It's really 100 different diseases. You know, liposarcoma is totally different than leiomyosarcoma, which is totally different than undifferentiated pleomorphic sarcoma. So it's hard to develop immunotherapy for sarcomas. We don't have good biomarkers for sarcomas. We don't have established antigens for sarcomas, except for perhaps those that have some of the simple translocations. And this has turned out to be a big one. This is something done in our lab here at Hopkins, but this is this work isn't just done in our lab. This is an example of some of the work that we've done here. But there's a lot of focus on the tumor microenvironment, and that you need to have T cells in the microenvironment for immunotherapy to work. And sarcomas are very protected. You know, how do you get T cells in your microenvironment? If you look at the cancers in which immunotherapy has worked, skin cancer. Skin cancer, your skin is constantly being ionized by the sun. You're constantly getting radiation. That's a pro-inflammatory thing. So those tumors have a lot of surrounding T cells in the first place. They're very responsive to chemotherapy. Lung cancer has enjoyed advances in immunotherapy. Why? People smoke. People are constantly inhaling pollution. That's a pro-inflammatory thing. We have a lot of T cells in those cancers. So those are the cancers that are enjoying success in immunotherapy. Where's the sarcoma in your thigh? What you know, inflammation are they seeing? None. They're protected. So mesenchymal tumors are very protected from those pro-inflammatory events. And if you look at the sarcomas that do react to chemotherapy, there's a Hopkins patient, scalp angiosarcoma. These respond. And why do they respond? Probably because they're on the surface. The sun is seeing them, and these tend to have a lot of T cells around, and these are the ones that are going to respond to immunotherapy compared to, let's say, an angiosarcoma in the thigh. So I'll end on that. We owe Coley, I think, a debt of gratitude and an apology, I think, for how he was treated. He really did a lot for immunotherapy, and he didn't know why he was right, so he couldn't explain to people why he was right, but he was right all along. This is a monograph. I collect a lot of these old books. This is one that I have that I took when I was in New York. Again, his daughter ended up becoming a scientist and documenting his cases, and she's published several of these monographs. And so, you know, be curious, question why you do things in the first place. You know, I look at the history of radiation and how that came to be the way we treat sarcomas. And if you start to go back and look at why those decisions were made, it's fascinating, really. I find it very fascinating. So I'm going to end there. This is our sarcoma team at Hopkins. I love our team. We have a great team. I think it very much mirrors the UCSF team, which sort of seems to be a close family team too. And again, thank you for having me. It was nice to speak with you this morning. I appreciate it.
Great. Thank you so much, Dr. Morrison. Thanks for joining us. And like you said at the onset, definitely wish that we could have had you here in person, but definitely appreciate you taking the time. And that was a great lecture. Really appreciate all the history. And we could open it up to questions. Rosie, see your hand up.
Oh, that was an excellent talk. Thank you so much. I have so many questions. I'm really interested in sarcoma immunotherapy, and we've done some work on it here. And we actually looked at the tumor microenvironment for soft tissue sarcomas in extremity and found that size and depth really altered what the tumor microenvironment looked like. But anyway, my question for you is, the Jay's paper from 2005, showed a marked survival advantage for these kind of naturally occurring infections in osteosarcoma. Mm-hmm. And then there's been several retrospective studies trying to find the same outcome for soft tissue sarcomas. And to my knowledge, they haven't really shown that a postoperative infection for a soft tissue sarcoma really influences survival. And one thing I've been thinking about, and one of my mentors here, James Johnston, very interested in this as well, his theory is that when you get an implant infection for a patient with limb salvage osteosarcoma, that infection just hangs around for a long time. So he thinks the survival advantage is because you're getting this constant stimulation of the immune response because it's so hard to eradicate an implant infection. Other people think, well, is it because you're getting a form of osteomyelitis and the antigens on bone cells are similar enough to osteosarcoma cells that you're getting more of a cross-reactivity of the immune system. So it's primed for the osteomyelitis as a result of the infection, but then it's able to also find any osteosarcoma cells. Do you have any thoughts on the mechanism and why there's a difference in soft tissue sarcomas versus osteosarcoma in the literature?
I mean, obviously the answer to it is far more complicated than I presented it. I simplified it very much. If all it took was an infection to cure a patient with osteosarcoma, we would jump on that bandwagon right away. So there is more to it than that. I do think that osteosarcoma, even that's not just one disease, but at least that's closer to being one disease compared to soft tissue sarcoma. And so I think I like that thought that maybe the bone cells are more closely aligned with an osteosarcoma cell, so it would be easier to develop immunity to that. It's true that to make immunotherapy work, you have to keep stimulating. The thing, Coley injected people weekly for months to try to keep that infection going, to keep the immune system primed and going. But I don't think what has ever been done, and now that I'm talking about it out loud, I'll look into it. I don't think whatever has been done is if you were to break down soft tissue sarcoma by subtype and do that same analysis, you might come up with some subtypes in which infection does give you a survival advantage. And that's one of the main problems in any sarcoma research. You know, again, it's 70 different diseases. It isn't just one disease. And when you throw them all together, the data is uninterpretable. But I bet there are some tumors that naturally, not just these surface ones that I just showed, but that naturally have a tumor microenvironment that's more conducive to immunotherapy or to infection stimulating that immune response. And perhaps you might see a differential survival advantage following infection in those. It is fascinating though. It's totally fascinating.
So Carol, I'd like to thank you for that tour de force of soft tissue sarcoma history. Having a Polish American wife, I do want to compliment your shout out to the brilliance of the Polish woman, and also pointing out the failings of James Ewing, which I didn't know about till I read the Radium Girls, that he was an expert witness for the radium dial industry.
Yeah.
But at any rate, to encapsulate the 25-year history of soft tissue sarcoma treatment in the Bay Area, I would say that when I came in '96, I was very interested in chemotherapy, having trained with Chappie, and Terry Jahan was here from medical oncology, had a great interest in neoadjuvant chemotherapy. And we also had Mobitron #1, intraoperative radiation therapy machine #1 in the nation. So we had an IORT interest. And at Stanford, they had medical oncologist Charlotte Jacobs, but their radiation therapists were sort of took primacy, and David Moeller would treat with preoperative radiation at Stanford, and I treated with preoperative chemo. And I think one thing, quite honestly, that needs to be sort of taken into account is that when you have a program where there's a single surgeon, you're busy and you need to get those big soft tissue sarcoma on the schedule, maybe with a vascular surgeon, maybe with IORT, and you can't do that case next week as soon as the pathology comes back. So if you have something to delay surgery so you could get the case on electively, quite honestly, whether it's chemotherapy or radiation therapy, I think that plays a role. So as 25 years has marched on, Stanford and UCSF experience has kind of changed. Terry Jahan has retired, and I'm sort of slowing down and seeing the limitations of chemotherapy. We now have 3 different soft tissue sarcoma medical oncologists and a new one coming in the summer. And Stanford has gotten Kristen Ganju, who's very interested in chemotherapy. And so both programs now have 3 orthopedic oncologists. So we have a little bit more luxury to try to individualize soft tissue sarcoma care. And I think it's fair to say Dr. Westrack, Dr. Zimmel are doing more preoperative radiation therapy. And maybe as a result, buying the infections, which I never wanted to deal with because, when you're all alone in practice, you don't want to have complications, big wounds and flaps and takebacks and washouts. But when you have 2 or 3 surgeons, maybe those infections are a little bit more tolerated in terms of the scheduling. And as you just told us, maybe the soft tissue infections are good for patients. So it's coming full circle, and maybe the future will be pre-op radiation and infections.
I need to stress, I'm not advocating that people purposefully infect their surgical wounds. I don't think that's the answer. But there is, there's radiation data to support that preoperative radiation in and of itself creates a pro-inflammatory environment that creates antibodies to that area that can be protective. And if you look at that randomized trial from O'Sullivan, when they did their initial analysis, the patients with preoperative radiation had better survival. That whole ascopal effect of the radiation causing, some systemic problem. So I think it's super complicated. I certainly don't pretend or espouse to know all the answers, but I do think there's something there that we haven't quite figured out how to harness to our advantage to help our patients.
Great. I think we're just a little bit past time, and if there are any other questions or comments, maybe speak up now. Otherwise, we'll look to probably wrap up.
Yeah, I talked a little bit there. I get excited about.
No, I think this is fantastic, and but you know, on behalf of our department, Dr. Morris, thank you. I think case conference this morning was really educational, and then your lecture was outstanding, and you know, really appreciate you joining us, taking the time, and hopefully we'll be able to see you out here in person at some point.
I look forward to coming. Thank you again for having me. I really appreciate it, and congrats, Rosie, Melissa, and Rich on having such a great program out there. Thank you.
Thank you so much, Carol. Thank you.
We'll see you in Baltimore.
That's right, for MSTS.